Great. Thank you so much, Adiba. It's a real pleasure to be here with you all tonight. Thanks for coming, everyone. This is a list of my disclosures. So I've been asked, as you heard, to do a quick update on current and future trends in antiretroviral therapy. And, a quick disclaimer, I totally appreciate all of Thomas's thoughtful comments just now about how broad we need to be thinking when we're trying to think about how best to provide proper person-centered care for people living with HIV. My comments are really restricted to the narrow focus of antiretroviral therapy. And I thought I would just start by thinking about, reflecting on what the goals of that therapy even are. And I think it's fair to say that they fall into these three broad buckets. So we want therapies that obviously have efficacy, good safety, and acceptability. If we drill down into what that actually means, on the efficacy side of things, clearly we want therapies that are able to achieve suppression of viremia and allow immune reconstitution to occur. On the safety side, obviously, we need to minimize toxicities. And from the acceptability perspective, we want to minimize side effects, which are not exactly the same thing as toxicities. We can think of them as issues of tolerability and also decreased pill burden. But if you look at these objectives, we've actually pretty much achieved some of those, or all of those, really some time ago in our field. And so today, I think we can evolve those goals a little further and say we want to, on the efficacy side of things, not only suppress viremia, but do so quickly, and achieve rapid suppression. And we want to do so with drugs that have a high genetic barrier to resistance so that we can overcome existing resistance mutations that may exist in the virus, prevent the emergence of future resistance mutations. Clearly, we need to continue to minimize toxicity, but we also want to minimize drug interactions. And I think we need to remember that interactions with concomitant medications, with gender-affirming hormones, are really important safety issues as well. And then on the acceptability side of things, we want to not only minimize side effects, but I think in today's age, we should really be demanding excellent tolerability for our therapies and having therapies that impose minimal burden on people's lives overall, not only from the perspective of what it takes to take those medications logistically and adhere with them, but also thinking about their psychological acceptability to people, their privacy, their safety as well. So I'm going to put those three topics just at the top of the slide here for a moment, and we'll briefly touch on each of them in the next few minutes. But before we do that, just a quick overview of what our first-line treatment options are according to various guideline bodies around the world. So you can see from the flags where these all come from and the dates, at least for the versions that I've plucked these guidelines or these recommendations out of. If we start in the country that we're located in right now, the Australasian Society for HIV Medicine has recommendations from a few years ago now saying that first-line therapy can include bictegravir with TAF-FTC or dolutegravir with the bacavir 3TC, dolutegravir with the tenofovir-based backbone, or raltegravir is still on that list. And we also see the appearance of a two-drug regimen, dolutegravir with lamivudine, for the first time. In the middle, we see American guidelines. The DHHS has really a similar list, except that raltegravir is no longer on that list of recommendations. The European guidelines are a little bit broader. They do include the raltegravir, as well as doravirine as an NNRTI-based regimen. And then the WHO guidelines, of course, speaking to a broader audience, low and middle income country settings as well, is really focused on dolutegravir with tenofovir or efavirenz with a tenofovir FTC backbone. So if you look at this jumble of letters, a few things stand out. Clearly, we're in the integrase era, and we have been for a number of years. And, one of the things that class of drugs, of course, can achieve is that efficacy goal I mentioned a moment ago of achieving not only virologic suppression, but doing so rapidly, right? So here's an example of some data from a few years ago now from an arbitrarily picked trial, the single trial comparing dolutegravir with efavirenz, and really showing that really nice separation of the two curves in terms of how quickly people achieve an undetectable viral load of less than 50 copies. And that really has clinical meaning, right? We know that by achieving that undetectable viral load quickly, we can have benefits in terms of onward transmission. We know that undetectable viral load means untransmittable virus. We also know that at least theoretically, if this is, especially when this is initiated early in the course of infection, there can be advantages in terms of the size of the latent reservoir that can be formed. So potentially some implications for cure as well. What else in terms of efficacy? We're also interested in therapies that have a high genetic barrier to resistance. And you'll notice, of course, that on that list of recommended regimens, of course, dolutegravir and bictegravir, our latest generation oral integrase inhibitors, appear prominently. And these are drugs that clearly have a high genetic barrier to resistance. We've seen that from a number of different lines of evidence, right? So at least 3 listed here. We've seen, first of all, negligible treatment emergent resistance occur in the naive trials for both of these agents. I've listed just a handful of those trials in that first bullet point. In the suppressed switch setting, we've seen that these agents can maintain efficacy when paired with 2 nukes, even when there is evidence of nuke resistance underlying that virus. And then even in the most extreme setting where we stress the drugs the most in terms of folks who've experienced virologic failure, we see that when these drugs are paired with 2 nukes in second-line therapy, they can still achieve virologic success despite, again, the presence of some nuke resistance. And some examples of trials that have demonstrated that principle are shown here. We've seen some other data just earlier today at this conference that suggests that is true in other settings as well, combining dolutegravir, for example, with just lamivudine. So clearly we're doing pretty well on the efficacy front. What about the safety front? We said that we want to minimize toxicities to our patients, and you'll notice that on the list of regimens, a number of the guideline bodies around the world are now recommending for the first time a 2-drug regimen in first-line therapy, dolutegravir with lamivudine. And that's really based on results from pivotal clinical trials like the Gemini trials 1 and 2, where we saw a very nice overlap between the 2-drug and 3-drug regimens that were studied in that trial. This is specifically what was being compared, dolutegravir with 3TC versus dolutegravir with TDF and FTC. And we see on the left a really nice comparability in the virologic success rate seen in the Gemini 1 and Gemini 2 trials, whether we're looking at on the right the intention to treat or the per protocol analyses. So they clearly have efficacy. Did we see a safety signal? And indeed, largely because, of course, the comparator was a regimen that had TDF in it, we saw renal and bone advantages to the 2-drug regimen. So here you can see the difference in terms of creatinine, the glomerular filtration rate, renal markers like cystatin C. On the right-hand side, bone turnover markers being lower in the absence of that TDF agent. So when we look at this overall, clearly we did see not only that there was adequate efficacy, but actually a safety benefit in this particular example to using a 2-drug regimen. Now, 2-drug regimens have been looked at for a long time, right? And often with the goal of trying to minimize the number of molecules that are being ingested by a person living with HIV and therefore downstream having potential benefits in terms of safety. Obviously, I'm not expecting folks to be able to read this list. The point of showing this is just to illustrate that this is not a new concept, that there have been many trials that have looked at novel 2-drug regimens over the years with varying levels of success. So here's just a couple of examples. So another evidence-based 2-drug regimen would be dolutegravir with rilpivirine. Again, a nuke-sparing regimen demonstrated in the SWORD 1 and 2 trials to have good efficacy, so non-inferiority in that trial compared to an optimized, an alternative existing antiretroviral therapy regimen. Did we see a safety signal there? Well, actually, the adverse event profile was quite comparable. So efficacious, but similarly safe, I think we could say. Looking back a little further in history, we look back on this trial looking at raltegravir together with ritonavir-boosted darunavir and comparing that against ritonavir-boosted darunavir with TDF-FTC, seeing similar efficacy with some caveats as shown on the right-hand side of this slide. But in this setting, once again, we saw just a similar adverse event profile, and really illustrating that 2 drugs is not always better than 3 in terms of safety. It really just depends on what you're comparing it to. Here's just one last 2-drug regimen, the doravirine and islatravir combination. Here I'm showing you phase 2b data from a few years ago, but earlier at this conference just yesterday, we of course saw phase 3 data looking at this particular combination compared against bictegravir, TAF, and FTC. Again, the common theme being excellent efficacy, so comparable to, in this particular slide, doravirine with 3TC and TDF. In the study that we were presented yesterday, compared to BIC FTC TAF. But in terms of adverse events, again, when we compare against TDF, we see fewer adverse events with this combination. So, sometimes the two-drug concept has been met with a safety benefit. Sometimes it hasn't necessarily panned out as such, really illustrating the fact that I think there's equipoise to this idea that 2 is necessarily better than 3, but certainly if you compare it against commonly used drugs like TDF, which are recommended and widely used all over the world today, clearly they can be benefits. So finally, in terms of acceptability, where do we stand? Obviously, the trend that we are really excited about in the field these days and have been for a while is the advent of long-acting therapies, all of which at this time are injectable. So cabotegravir with rilpivirine on a 4-weekly schedule was demonstrated to have a non-inferiority to comparators in both the suppressed switch setting or the shortly after treatment-naive treatment initiation in the FLAIR trial. As demonstrated with these great virologic success data here. It's also been looked at in a Q8 weekly regimen, as you know, in the Atlas 2M and the SOLAR trial. And once again, demonstrating excellent virologic success. And so I'm not showing you the wealth of patient-reported outcome data that accompanied these trials that demonstrated that indeed there were acceptability advantages to the injection, all-injectable regimen that people really appreciated in terms of the benefits of privacy, of the psychological burden of not having to take a daily pill, being a reminder of HIV status in the folks taking the injectable regimens. Clearly, there are acceptability advantages to these sorts of regimens. And then the latest kid on the block, of course, lenacapavir. We've seen updates on this drug in many posters and oral presentations at this conference. Here are the data from the Calibrate study looking at this agent in combination with oral drugs and first-line therapy, demonstrating once again excellent efficacy, comparable and non-inferior to leading daily single-tablet regimens like BIC, TAF, and FTC. And really pushing the envelope in terms of how far we can go with the acceptability of taking therapy. If it only involves 2 visits to the clinic per year, hey, wouldn't that be fantastic? Of course, this particular trial didn't quite demonstrate that, but earlier this year we did see for the first time proof of concept that there can be such a regimen perhaps when lenacapavir was combined with these 2 monoclonal antibodies, teripalimab, zinlervimab. Hopefully I did okay with that, was demonstrated in this very small trial to have excellent efficacy in 9 out of 10 individuals receiving that. So we look forward to much more advance in the field of long-acting therapy, not only with injectables, perhaps long-acting oral formulations, depot formulations, et cetera. So with those brief comments, I'll just summarize. Clearly, our regimens continue to improve in these 3 broad domains of efficacy, safety, and tolerability, and acceptability, I should say. We've seen a trend towards reducing the number of medications or molecules that a person actually needs to take to achieve those efficacy goals, and dolutegravir 3TC is a good example. That's right there in first-line treatment recommendations, hopefully can be associated with improved safety. And then we've seen, of course, the development and rollout of long-acting regimens, including rilpivirine, Q4 or Q8 monthly, with much more, hopefully, still to come. So look forward to the rest of our discussions, and this is my team. Thank you so much.